My name is Ashlyn Riedesel, and I am a clinical pharmacist at Sanford USD Medical Center. And my project looked at fixed-dose prothrombin complex concentrate for the reversal of apixaban, rivaroxaban, and edoxaban. First, let's jump into the background of my study. Factor Xa inhibitors like Xarelto and Eliquis have become first-line treatment options for patients requiring anticoagulation. But until recently, there has not been an FDA-approved option for the reversal of these agents. Andexanet alpha, or Andexa, was FDA approved in 2018, but it does have some limitations for use. 4-factor PCC that contains activated factors 2, 7, 9, and 10, as well as protein C and S, has traditionally been used for warfarin reversal, but it is now being used off-label for the reversal of factor Xa inhibitors. Doses have ranged from 25 to 50 units per kilogram, and recent trials have evaluated utilizing a fixed dose of 2,000 units for all patients requiring reversal of factor Xa inhibitors. This fixed dose was endorsed by the Anticoagulation Forum in March of 2019. In conjunction with our trauma and neurocritical care physicians, as well as the anticoagulation team here at Sanford USD Medical Center, I created a fixed dose protocol for 26 sites within the Sanford Health Enterprise, and those sites transitioned from weight-based dosing to fixed dosing in early 2020. I utilized a retrospective chart review to identify patients who received 2,000 units of PCC via the electronic prescription number from January to April of 2020. I followed patients for 30 days or until their death. Patients were included in my trial if they were at least 18 years of age, on apixaban, rivaroxaban, or edoxaban, and they must have received 2,000 units of PCC. I looked at a variety of different outcomes. My primary outcome was all-cause mortality at 30 days. My primary safety outcome was the incidence of venous thromboembolic events, myocardial infarction, as well as ischemic or hemorrhagic stroke. I also looked at the resumption of anticoagulation, the patient discharge destination, as well as cost savings incurred to the health system by utilizing the fixed dose. Of the roughly 1,200 electronic prescriptions for PCC that I reviewed, I identified 48 individuals that met the inclusion criteria. The average patient was a 76-year-old male who weighed 85 kilograms. He had a creatinine clearance of roughly 78 and was likely on apixaban for a history of atrial fibrillation. Of note, I did have 7 patients with more than one indication for an anticoagulation. An edoxaban was included in my study, but I did not have any patients on the medication. A majority of my patients were treated with PCC due to the need for reversal for immediate surgical intervention or for an intracranial hemorrhage. Of the intracranial hemorrhages, there were 5 patients who required neurosurgical intervention. There were also patients who received PCC for other indications that did not fit on the above categories, and those are listed below. 14 of my patients received blood products in addition to PCC that were given within 24 hours of PCC administration. All of the patients who received blood products received packed red blood cells, and 6 of those patients also received fresh frozen plasma in addition to the red blood cells. Part of my implementation allowed providers to redose PCC if they felt that it was warranted in their patient. There was 1 patient who received additional PCC. However, this occurred prior to implementation of the fixed dose protocol, and the patient had a spinal hematoma that involved nearly their entire spinal cord, and ultimately they received 4,000 units total of PCC. As a part of my study, we evaluated laboratory monitoring to see how efficacious the PCC was at improving our laboratory values. Now, as you can see, there is some improvement in INR following administration of PCC. In general, hemoglobin tended to decrease but stabilize after PCC administration. Moving on to my primary outcome, there were 5 deaths as a result of my trial. And when looking at primary safety outcomes, we had 1 incident, and this was an ischemic stroke that occurred 8 days after PCC was administered to the patient, but the patient was able to discharge home. Looking at secondary outcomes, 52% of my patients were resumed on anticoagulation therapy, and a majority of the patients who did have their anticoagulation resumed, around 70%, were actually resumed within 5 days of the patient receiving PCC. The others that did not have their anticoagulation resumed, but it was likely to be resumed in the near future, as I only had a short 30-day window. And in general, my patients were able to return to their former place of residence or have a short rehabilitation stay or swing bed stay prior to returning home. We look at the cost savings. I identified $432 savings per fixed dose patient. And when you compare this to andexanet alpha, the estimated cost of andexanet alpha for the 48 patients in my study would have been over $850,000. So my study did include patients who received both weight-based and fixed-dose PCC. Like I mentioned earlier, the protocol was implemented in early 2020. So therefore, 28 of my patients received a weight-based dose that equated to 2,000 units, and 20 of my patients received the newly implemented fixed-dose protocol. In general, a majority of my patients, or almost all of them, were relatively healthy at the time of their reversal. They all had good renal function, high Glasgow coma scores, meaning they were mostly coherent, and a majority were a healthy weight. Surprisingly, 5 of my patients ended up receiving vitamin K in conjunction with their PCC. When diving into this a little deeper, I did notice that this was most likely occurring in 2017. 4 of the 5 actually occurred in 2017 when we were first implementing our PCC protocol at the medical center, and likely was a knowledge gap. Only 14 patients required the use of additional blood products, and in general, we would expect to see more use with the indications that are listed, which also reiterates that our patients were very healthy at the time of reversal. And like you can see with the laboratory monitoring, there was a reduction in INR seen following PCC administration, which could be caused by the PCC or intrinsic factors. And like I mentioned earlier, a majority of patients were able to be resumed on their anticoagulation within 5 days of PCC administration. There are some limitations to my study. Like I mentioned earlier, we included patients who received either a weight-based or a fixed dosage of PCC, and it was a single-armed retrospective observational study with a small sample size, and not all of the anticoagulants were adequately represented in the patient population. So this data set is consistent with the current information available for the use of fixed PCC. We were able to demonstrate a cost savings to the health system, and this data does support the need for a large prospective randomized controlled trial. Thank you.